Welcome to the Surgical Educator's Advanced Online Operative Surgery Masterclass. Allow the words in the podcast to permeate into your mind. In this session, we're going to discuss the various steps of thyroidectomy. Visualize the patient or patients discussed in your mind's eye, or run a mental movie of the patients to have an indelible impression. By doing this mental rehearsal, you will experience an immersive and transformational learning experience and will develop the much-needed confidence before actually going to do the surgery yourself. This will eventually result in achieving excellence in surgery. Thank you.
Absolutely.
So, diving right in, we're basing today's deep dive on a phenomenal, meticulously detailed operative presentation by Dr. B. Selvaraj, professor of surgery at Malaga Manipal Medical College.
Right. It's an incredible resource.
It really is.
Yeah.
And I want you, the listener, to just imagine for a second that you're trying to diffuse this incredibly complex explosive device.
Yeah, that's exactly what it feels like.
Right. Because the wires are just fragile, they're nearly microscopic, and they are literally pulsating with blood.
Uh-huh. And worse, this device is wrapped directly around your patient's airway.
Exactly. Sitting right on top of the main vascular highways going straight to the brain. It's high stakes.
It's the ultimate high-stakes environment. I mean, the anterior neck is unforgiving. So what we are doing today is building that unshakable cognitive map.
Right.
So that when you're finally under the OR lights, scalpel in hand, you're not guessing. You're operating on pure, highly educated instinct.
I love that. Operating on instinct. So let's pull the presentation looking at slide 1 and 2 here, which covers indications, anesthesia, and the initial setup.
Perfect place to start.
Right. So Dr. Selvaraj lists 3 main indications for a thyroidectomy. We've got thyroid malignancies, multinodular goiters, and Graves' disease.
Yeah, and functionally you have to divide your surgical thinking into 2 completely different buckets here.
Okay, what do you mean by that?
Well, you have your structural problems, like the multinodular goiters and the malignancies, right? And then you have your metabolic problems, which is Graves' disease. So let's look at the structural side first.
The space-occupying lesions.
Exactly, because, the human neck is basically a confined cylinder. There is absolutely no extra room in there.
Just packed tight.
Completely. So if you have this massive growing goiter, it physically displaces everything. I mean, it can wrap around the trachea and literally compress the cartilage rings until the airway is just a tiny slit.
Wow, so the patient can barely breathe.
Right. Or it presses backward against the esophagus, causing severe dysphagia. They can't even swallow solid food. So the mission there is purely mechanical relief. Excavate the physical obstruction.
Restoring the normal anatomy. But then on the flip side, looking at the metabolic bucket with Graves' disease, it's totally different, right? Because it's not always a massive goiter.
No, not at all. With Graves', the gland has basically gone completely rogue on a cellular level.
Because of the antibodies.
Right. The immune system is churning out antibodies that mimic TSH, thyroid-stimulating hormone, and they just relentlessly bombard the thyroid.
Turning it into an overdrive factory.
A toxic factory, pumping out dangerous levels of thyroid hormone. And the key thing for a surgeon to realize is that because the factory is in overdrive, the physical tissue literally transforms.
How so?
A Graves' gland is aggressively hypervascular. I mean, it is just engorged with blood. It's soft. It's friable.
Friable meaning it just tears easily.
Exactly. It'll bleed torrentially if you handle it with anything less than absolute microscopic precision.
That's terrifying. So you have to totally adapt your tactile approach depending on the disease. But regardless of whether it's structural or metabolic, the anesthesia plan is non-negotiable, right?
Completely non-negotiable. General anesthesia with endotracheal intubation, period.
GAET. I always picture the endotracheal tube as like the scaffolding of a building you're renovating.
That's a great analogy.
Right. You wouldn't knock down load-bearing walls without temporary supports. And in the neck, you are scraping tissue right off the trachea. You cannot risk the airway collapsing.
Or the vocal cord spasming, because later on we're dissecting right next to the recurrent laryngeal nerves.
Which control the vocal cords.
Right. And if you irritate those nerves, the cords can spasm shut. If they just have a mask on, they stop moving air entirely. But with a cuff tube physically sitting between the cords,
the airway is stented open.
Exactly. It's the ultimate safety net for the anesthesiologist and the surgeon.
Okay, so airway is secure. And before we move off these first slides, there's a quick mention of initial positioning, the semi-Fowler's position with neck hyperextension.
Right. We'll get into the exact biomechanics of that in a minute, but it's all about hoisting the gland up into the surgical field.
Got it. Okay, so transitioning to slide 3. This slide is entirely focused on preoperative preparation, the metabolic setup.
This is the reconnaissance mission. The workup has to be bulletproof.
Yeah, the slide lists thyroid function tests, FNAC, ultrasounds, scintigraphy, bone scans. It's a lot.
Information is your primary weapon here.
Yeah.
You have to know the exact microscopic nature of what you're cutting into.
Especially the fine needle aspiration, the FNAC, right?
Crucial. It tells you, is this a benign colloid nodule or is it a papillary thyroid carcinoma?
Because that dictates the whole surgery.
Exactly. You don't want to just do a simple lobectomy, get the pathology report back 3 days later, and realize you left half a cancerous gland behind. You need to know if you're committing to a radical total thyroidectomy right from the start.
Makes sense. But in this whole diagnostic phase, Dr. Selvaraj includes this massive, bold warning, like a golden rule.
Oh, the contrast warning?
Yes. Never use iodine-containing contrast.
Right.
But, I mean, IV contrast is used in CT scans literally thousands of times a day. Why is it forbidden here?
Because of the underlying metabolic state. If a patient is already hyperactive, maybe they have a toxic multinodular goiter.
Right.
Those thyroid follicles are starving for raw materials to make more hormone. And what's the main raw material?
Iodine.
Exactly. So if you inject a massive concentrated dose of iodine contrast for a CT scan,
It's like dumping a truckload of raw materials into a factory that's already overproducing.
you're throwing gasoline on a smoldering fire. The gland takes up all that iodine and instantly converts it into a massive surge of active thyroid hormone.
Wow.
It triggers what we call the Jod-Basedow phenomenon, iodine-induced hyperthyroidism,
Which leads to a thyroid storm.
a completely catastrophic thyrotoxic crisis.
What does that actually look like for the patient?
Multisystem failure. The heart rate spikes into dangerous tachycardias or AFib. Their core temperature skyrockets.
Oh.
Delirium, heart failure.
Oh, wow.
It carries a very real, very high mortality rate. So we absolutely ban iodine contrasts pre-op.
That is wild, and that perfectly sets up the next point on slide 3. For hyperthyroid patients, you have to bring them back to a euthyroid state, a normal state before surgery, using anti-thyroid drugs and propranolol.
Operating on a hyperthyroid patient is basically operating on a live bomb.
Because of the physical stress of the surgery.
Yeah, just the physical act of the surgeon squeezing and retracting the gland during the operation literally forces massive amounts of preformed hormone straight into the bloodstream.
Oh, I hadn't even thought of that. You're physically squishing the hormone into the blood.
And exactly. If you haven't metabolically blocked them first, you'll induce a fatal thyroid storm right on the OR table.
So you use drugs like methimazole to shut down the factory line,
Right, stopping new synthesis.
and then propranolol, a beta blocker, to shield the heart from whatever is already floating around.
Propranolol is an absolute lifesaver. It slows the racing heart, stops the tremors, calms the whole physiological storm down.
Okay, this all tracks. But wait, this brings up a massive contradiction on the slide.
I know exactly what you're going to say.
Right, because we just said injecting iodine contrast is a cardinal sin. It causes a thyroid storm.
Yeah.
But the very next bullet point says we must administer Lugol's iodine for 10 days prior to surgery.
Yeah.
How does giving them Lugol's iodine not trigger the exact same Jod-Basedow thyroid storm we just tried to avoid?
It's one of the most brilliant, beautiful paradoxes in endocrine physiology. It all comes down to a fail-safe mechanism called the Wolff-Chaikoff effect.
Okay, let's break that down. What is the Wolff-Chaikoff effect?
So a small or moderate dose of iodine fuels the fire, right? But a massive, sudden, overwhelming flood of pharmacological iodine, which is what Lugol's is, it actually triggers an emergency shutdown sequence in the thyroid cells. When the iodine concentration gets insanely high, it temporarily paralyzes the enzyme thyroid peroxidase.
Which is the enzyme that binds the iodine to make the hormone.
Exactly. The factory floor gets so flooded with raw materials that the machinery literally jams and breaks down. Hormone synthesis drops to absolute zero.
A biological circuit breaker. That's incredible. But why do we do it specifically for 10 days before the surgery? Like, what's the mechanical advantage for the surgeon?
The metabolic shutdown is nice, but the real magic is physical. Because the hormone production stops, the massive blood flow to the gland suddenly drops.
Right.
The cells actually shrink. So you take this beefy, engorged, bleeding Graves's gland.
The friable sponge.
Yeah. And over those 10 days, the Wolff-Chaikoff effect transforms the tissue. It becomes firm, pale, and drastically less vascular.
Wow.
You turn a nightmare, bloody mess into a solid, manageable organ that you can safely dissect and ligate.
Pharmacology, directly dictating surgical anatomy. That's just brilliant. Okay, last point on slide 3. The workup must exclude MNN syndromes,
Well,
multiple endocrine neoplasia.
extremely important.
But if we're focused on a mass in the neck, why are we screening for a systemic genetic syndrome?
Because of the lethal company that medullary thyroid cancer keeps.
Yeah.
Patients with MNN type 2 get thyroid cancer, yes, but they also frequently have undiagnosed pheochromocytomas.
And that's a tumor on the adrenal gland, right,
Mhm.
sitting on the kidneys.
Right, and it secretes pure concentrated adrenaline. Yeah, so if they have an undiagnosed pheochromocytoma and the anesthesiologist puts them to sleep and you cut their neck open,
The surgical stress triggers the adrenal tumor.
it dumps a massive payload of adrenaline directly into their circulation instantly.
A cataclysmic storm.
Blood pressure spikes to like 250 over 150. They stroke out, have a heart attack, or go into lethal arrhythmias right there on the table.
So you have to screen the urine and blood for metanephrines first.
Always. If you find a pheochromocytoma, the thyroid surgery is canceled immediately. You take out the adrenal tumor first, let them recover, and come back for the thyroid weeks later.
Unbelievable. Just vital checklists everywhere. Okay, moving on to slides 4 and 5. The patient is optimized, airway is secure. Now we look at positioning and draping.
This is where the physical geometry of the operation starts.
Right, the semi-Fowler's position. We place a firm pillow right between the scapulae, the shoulder blades, head on a ring to hyperextend the neck, and then we elevate the head of the bed 15 degrees.
Let's run the mental movie here. Patient is supine. When you shove a firm lift between their shoulder blades, you force the thoracic spine up,
Right, expanding the chest.
and the shoulders drop back down toward the table. With the head on a ring, the cervical spine falls into maximum extension.
Stretching the neck out.
Exactly. Because normally the thyroid sits pretty low. Sometimes the lower poles are literally dipping down behind the sternum, hiding in the chest cavity.
Totally out of reach.
By heavily hyperextending the neck, you physically hoist the entire laryngotracheal complex and the thyroid with it up and out of the thoracic inlet. You project it anteriorly, right under the skin.
Maximizing the real estate between the jaw and the collarbones.
You create a taut, wide-open canvas.
Makes sense. And what about tilting the whole bed up 15 degrees? Why fight gravity?
Well, actually, you're using gravity to fight bleeding. The veins in the neck, the jugulars, the thyroid plexuses, they don't have valves like the veins in your legs do. Blood flow there is completely dependent on gravity and chest pressure. By tilting the head up 15 degrees, you encourage all that venous blood to drain back down into the heart.
Decompressing the veins.
Exactly. They collapse. So when you make your incision, you're not instantly dealing with engorged, bleeding veins all over your surgical field.
Such a smart mechanical trick. Now, there's one tiny detail here before prepping the skin that I found fascinating. Protecting the eyes.
A meticulous surgeon leaves absolutely nothing to chance.
Because under general anesthesia, the patient loses their blink reflex, right?
Completely abolished. The eyes naturally rest slightly open. And think about what we're doing. We're pouring harsh, alcohol-based chlorhexidine prep all over their face and neck.
And swinging metal retractors around their head.
Right. If a single drop of that prep runs into their open eye or a drape brushes the cornea, they wake up with a massive corneal abrasion. They'll be screaming in pain from their eye, totally ignoring their neck surgery.
So taping the eyelid shut immediately after intubation is just a non-negotiable step. There's holistic care. I love it. So the eyes are safe. We drape the field double sterile towels, exposing mandible to sternal notch. And then we get this incredible technique, the silk thread trick.
It's true surgical artistry, a classic maneuver.
I mean, before the surgeon even uses a marker, they take a piece of heavy silk suture, like a 2-0 silk, pull it tight like a grotto, and just press it firmly into the skin of the neck.
Just for a few seconds.
And it leaves a temporary red indentation. But like, why? Why not just freehand a line with a surgical pen?
Because human skin moves. Especially now because the neck is stretched into severe hyperextension. The skin is completely distorted from its normal resting position.
Right.
If you freehand what looks like a straight line on a stretched, curved cylinder,
When they wake up and sit normally, that line is going to be wavy and crooked.
it'll heal terribly. It might cut right across the natural skin folds. And look, the cosmetic outcome of a thyroidectomy is deeply important for the patient's psychology. It's right on their neck for the world to see.
So the taut thread guarantees a perfectly symmetrical geometric line.
Exactly. And the surgeon carefully aligns that thread to be perfectly parallel with Langer's line.
Langer's lines, those are the natural cleavage lines dictated by the collagen fibers in the skin, right?
You got it. If you cut parallel to a Langer's line, the natural tension pulls the wound edges together. You get a hair-thin, basically invisible scar.
Oh.
If you cut across the line, the collagen pulls the wound apart, and you get an ugly, thick, hypertrophic scar. So the silk thread into a natural crease ensures cosmetic perfection.
Anatomy, physics, and art all blending together. Okay, transition to slides 6 and 7. The incision and flat mobilization. The physical operation begins.
The moment of truth.
The slide calls for a Kocher's low collar incision.
Named after Emil Theodor Kocher, a true giant in our field. You know, before Kocher refined this in the late 1800s, trying to remove a thyroid was considered practically surgical suicide.
Really? What was the mortality rate?
Around 50%.
50%.
Mostly from catastrophic hemorrhage or infection. Kocher introduced meticulous hemostasis and this exact incision and dropped the mortality to less than 1%. He won a Nobel Prize for it.
We are literally walking in the footsteps of a legend. Okay, so we make the Kocher incision through the skin fat, and then we hit the platysma muscle. The slide says divide the subdermal platysma in the same line.
Right. The platysma is fascinating. It doesn't connect bone to bone. It's an evolutionary leftover, basically.
Like the muscle horses use to twitch flies off their skin.
Exactly, the paniculus carnosus. In humans, it's just this paper-thin, fibrous sheet covering the front of the neck.
But surgically, it's the roof of our operative space. So we divide it horizontally, and then we have to create our working envelope by mobilizing the upper and lower flaps.
We have to lift the roof off. We grasp the upper edge and dissect all the way up to the Adam's apple, the thyroid cartilage.
And the lower edge down to the suprasternal notch. But wait, if you peel a massive flap of skin from the chin down to the collarbone, aren't you tearing all the blood vessels that keep that skin alive?
That is exactly why the platysma is so architecturally brilliant. The blood vessels supplying that skin run in the subdermal plexus, which sits superficial to the platysma.
Sandwiched between the muscle and the fat.
Right. So we don't separate the skin from the muscle. We lift the skin, fat, and platysma all together as one composite unit. We do our dissection deep to the platysma in the subplatysmal areolar tissue plane.
The space underneath.
Yes, because that plane is filled with loose avascular connective tissue. You can just sweep your instruments through it with practically zero bleeding.
So the platysma acts as a shield, protecting the blood supply above it.
Exactly. You pop a self-retaining Joul's retractor in, crank it open, and now you're staring at the midline anatomy of the neck.
Which brings us directly to slide 8 and 9. Venous ligation and deepening the exposure.
Right, because immediately you run into the anterior jugular veins.
Running vertically down the center. The slides say we must suture ligate and divide these veins. Why suture ligate? Why not just zap them with the electric cautery? It's way faster.
Because the neck is a dynamic pressure system.
Okay.
If you just burn a large vein closed, it leaves a weak heat-sealed clot. When the patient wakes up from anesthesia and coughs,
Their venous pressure spikes.
massively. And that weak clot will just blow right open and you'll have a massive hemorrhage under the closed skin. You must physically pass a suture around it, tie a knot, and cut it. Permanent security.
Secure the path. Okay, veins are gone. Now we see the strap muscles. Sternohyoid, sternothyroid.
Right.
They cover the gland like double doors.
And we need to open those doors without causing a bloodbath.
The instruction is to divide the strap muscles strictly in the midline.
This is pure embryological elegance. The right and left strap muscles meet perfectly in the center at a fibrous band called the linea alba, or the median raphe.
A seam.
Right. And because it's fibrous tissue, not muscle belly, it is completely avascular.
So you can just slice down the midline seam, part the curtains, and there's no bleeding at all.
Exactly. You retract the muscles laterally, and finally, there is the target.
But it's still wrapped up. It's encased in the pretracheal fascia, the false capsule.
Yes. And incising this false capsule is probably the most delicate tactile maneuver of the early operation.
You have to dissect laterally between the false capsule and the true capsule of the thyroid gland.
This is the make or break moment. If you stay in this microscopic plane, the surgery is beautifully bloodless. If you miss it, you are fighting hemorrhage for the rest of the case.
I always visualize it like peeling a grape.
I love that analogy.
Yeah, the pretracheal fascia is like a secondary wrapper. The true capsule is the actual thin skin of the grape, which is totally fused to the wet, fleshy fruit inside.
And that true capsule sends fibrous bands diving deep into the highly vascular thyroid tissue. It's inseparable from the blood supply.
So if you scratch the skin of the grape, if you tear the true capsule, the pressurized fruit bleeds everywhere.
instantly obscuring your entire field. But if you carefully incise the false capsule and use a tiny piece of gauze to gently sweep it away,
You find that magical avascular areolar plane.
and the whole thyroid lobe just rolls right out of its bed, intact, dry, and gleaming.
It's just all about patience and touch. So we roll it medially, exposing the lateral edge. And moving to slide 10 and 11, we hit our first major tether, the middle thyroid vein.
The first true booby trap of the deep dissection.
You've mentioned it's dangerous. What makes it so treacherous?
It's the anatomy. The middle thyroid vein drains straight from the side of the gland directly into the internal jugular vein.
The massive water main for the brain.
Right. And the middle thyroid vein is notoriously short, sometimes just millimeters long, and paper thin.
Oh, wow.
And remember, you're currently pulling the thyroid gland medially to see it. If you pull too hard,
You transfer all that tension to the short little vein.
then it avulses. It physically tears right off the side of the internal jugular.
Huh.
Suddenly, you have a gaping hole in a major high-flow vessel. Dark blood floods the neck instantly.
And the torn vein retracts back into the tissue, right?
Exactly. It shrinks back into a pool of rising blood. You can't see it. If you blindly throw clamps in there, you'll crush nerves or arteries. You must handle the gland with extreme gentleness, spot the vein early, tie it twice, and cut it cleanly.
Okay, so lateral tether is cut. The gland pivots. Now we can pull it down to expose the peak of the mountain, the superior pole.
We are entering the domain of the superior pedicle.
The slide has a bold, golden rule here. We must clamp and divide the superior vessels as close to the gland as possible. Why is that distance so critical?
Because of an invisible threat. Everything we do at the upper pole is to protect the external branch of the superior laryngeal nerve.
Let's map that out. The superior thyroid artery comes down from the external carotid, and this tiny nerve runs right next to it.
Often intertwined with its branches.
And this nerve only controls one muscle, the cricothyroid muscle.
The primary tensor of the vocal cords.
Right, so functionally it controls the high-pitched vibrations.
Exactly. Your ability to yell, project your voice across a room, hit high notes, or just have normal emotional inflection in your speech.
So if your patient is a teacher or a singer or, podcaster,
If you crush this nerve, their normal talking voice might sound okay, but the second they try to shout for their dog, their voice just fails. It sounds breathy and weak. It's a devastating functional injury.
and the trap is that this nerve frequently crosses directly over the artery right before the artery hits the gland.
Right. So if a surgeon gets lazy and clamps the main trunk of the artery high up, away from the gland,
They catch the nerve in the clamp.
guaranteed.
Yeah.
But if you follow the first golden rule, dissect the vessels right down to the actual surface of the thyroid tissue and ligate them right there.
You stay below the crossing point of the nerve.
Precisely. You secure the blood supply without ever entering the nerve's territory.
And the slide actually notes a massive tech update here. Nowadays, harmonic scalpel has been used
A total game changer.
because before, you had to pass right-angle clamps, feed tiny silk ties around the back, tie knots in a dark, tiny hole.
While praying you don't tear the vessel, it took forever. The harmonic scalpel revolutionized it.
And it doesn't use electric cautery, right? No electrical burning.
No, it uses piezoelectric crystals in the handpiece. The metal blade vibrates at roughly 55,500 times per second.
That's incomprehensible.
It is. When you grab the vessels with the jaws and activate it, that intense microscopic friction denatures the tissue proteins. They melt into a highly secure, sticky coagulum that seals the vessel permanently.
And it cuts it at the same time.
In one fluid motion. 3 seconds, and the pedicle is divided.
And because it's friction, not electrical heat, the thermal spread is minimal, right?
Less than 2 millimeters of heat radiating outward, so you don't accidentally cook the nerve sitting right next door.
Technology perfectly augmenting anatomy. Incredible. So the upper half is fully mobile. We pull the gland downward and roll it, moving to slide 12 and 13. The inferior pedicle.
The true danger zone.
The slide says to handle the inferior thyroid veins first clamp divide, transfix. But the real core of this surgery is the inferior thyroid artery.
The lifeline. And neighbor to the most precious structures in the neck.
The instructions are so specific here. Ligate and divide inferior thyroid artery branches individually at the surface of the gland.
This is the second golden rule of thyroid surgery.
It's the exact opposite of the first rule. Up top, we stayed close to the gland. Here. Wait, no, it's the exact same physical action. We stay on the surface of the capsule.
Yes. We like it at the capsule, but for completely different physiological reasons.
Right, because looking at the plumbing, the main trunk of the inferior artery is massive. Why not just clamp the main trunk way out laterally and shut off the whole blood supply in 1 second? Why spend 20 minutes picking off tiny twigs on the gland?
Because if you clamp that main trunk laterally, you will trigger a metabolic disaster and potentially paralyze a vocal cord.
Let's talk about the metabolic disaster, the parathyroids.
We usually have 4 of them. Tiny little glands, size of a grain of rice, embedded in the fat on the back wall of the thyroid.
Regulating all the calcium in our blood.
Every heartbeat, every muscle twitch relies on them. And their primary, often only, blood supply comes from microscopic arterioles branching off the main trunk of the inferior thyroid artery.
So the inferior artery is the main water line. As it comes toward the thyroid, it gives off side pipes to the parathyroids, and then the main pipe continues into the thyroid capsule.
Exactly. If you clamp the main trunk laterally, you shut off the water main before the side pipes.
You instantly kill the parathyroid.
They will infarct from ischemia, but if you trace the artery all the way to the actual surface of the thyroid...
The side pipes have already branched off. You're downstream.
Right. You ligate only the terminal branches on the thyroid, perfectly preserving the circulation to those vital little glands.
Wow. And that's just the parathyroids. We also have to navigate the recurrent laryngeal nerve, the RLN.
The structure that keeps surgeons awake at night.
It provides the primary motor innervation to the vocal cords. And its path upward directly intersects the inferior artery coming inward.
Yes. And the terrifying part is, there is no blueprint. The RLN might pass in front of the artery, behind it, or right between the intertwining branches. It's totally variable.
So plunging a clamp into the lateral tissue to grab the artery is like playing Russian roulette with the nerve.
You'll crush it. So the only safe way is to gently, bluntly sweep the tissues until you visually identify the RLN in the tracheoesophageal groove. It looks like a glistening white string.
Once you physically see it, you trace it up.
And only then do you go back to the surface of the thyroid and ligate those terminal arterial branches, staying far away from the known path of the nerve.
Tedious, but absolutely necessary. So moving to slide 14 and 15, the pedicles are cut, lateral veins are gone, the gland is just anchored to the windpipe itself.
The final tether, Barry's ligament.
The slide says divide Barry's ligament to mobilize the gland.
It's a dense condensation of fascia bolting the thyroid directly to the tracheal rings, but it hides the lethal secret.
The RLN again.
Yes. As the nerve travels up to enter the voice box, it frequently passes immediately deep to, or even directly through, the posterior fibers of Barry's ligament.
It's literally embedded in the anchor you have to cut.
It's the final booby trap. If you just grab a clamp and hack through the ligament, you will sever the nerve millimeters before it enters the larynx.
So how do you do it?
You use a fine mosquito hemostat to microscopically tease apart the fibers. You physically push the nerve safely away, and then you divide the fascia.
And once it's cut, the slide says we just use electrocautery to peel the thyroid off the trachea.
Yeah, the heavy lifting is done. You're just coagulating tiny capillary bleeders.
Okay, so the lobe is mobilized. Now, if it's just a benign nodule on one side, we only do a hemothyroidectomy, right?
Correct. Just removing the diseased half.
And to do that, we have to cut across the isthmus, that bridge of tissue connecting the two halves over the trachea. The slide says clamp the isthmus, divide it, and oversew with interlocking continuous 3-0 vicryl.
Because that isthmus is highly vascular. You can't just slice it. You take a heavy Kocher clamp and crush a vertical line right through it.
The crushing damages the tissue and starts the clotting cascade.
Exactly. Then you cut along the clamp to remove the lobe, but you're left with a raw, crushed edge of thyroid on the trachea.
And when they wake up and cough, that crushed edge will just blow open and blight into the airway.
So we use 3-0 vicryl, an absorbable braided suture, to permanently sew it shut using a continuous blanket stitch.
An interlocking chain.
Like a series of micro tourniquets that physically strangle every little blood vessel. You take the clamp off and it's bone dry.
Perfect isolation. But switching gears to slide 16 and 17, what if the patient has bilateral disease, like a massive MNG or cancer? A total thyroidectomy.
Then you literally walk to the other side of the table and start the whole meticulous process over from the top.
And the slide screams in bold text, preserve parathyroids and recurrent laryngeal nerves. The mechanical steps are the same, but the physiological stakes are exponentially higher.
It's a completely different magnitude of risk.
Right, because if you do a hemothyroidectomy and accidentally cut the right RLN, The right vocal cord paralyzes.
Which is terrible. They're hoarse, they choke a bit, but the left cord still works, so they can breathe.
But if you're doing it total and you damage both RLNs,
Bilateral vocal cord paralysis.
Hmm.
The cords don't just fall open, they paralyze in the paramedian position. They fall dead center and slam shut against each other.
completely sealing the airway.
The second the anesthesiologist pulls the breathing tube out, the patient begins to asphyxiate. It's a catastrophic emergency. They usually need an emergency surgical hole in their neck, a tracheostomy, just to survive.
Oh my God. And the same logic applies to the parathyroids, right?
Absolutely. Take out the right-sided parathyroids by accident during a lobectomy, the left side takes over. The patient doesn't even notice.
But strip the blood supply off all four during a total thyroidectomy.
They plunge into permanent hypoparathyroidism. Without massive daily calcium and vitamin D supplements for the rest of their lives, their calcium crashes, causing severe muscle cramps, tetany, and lethal arrhythmias.
Which perfectly explains the alternative strategy on slide 17, the subtotal thyroidectomy.
Right, for purely benign disease. A masterclass in risk mitigation.
The slide says, preserve the parathyroid glands and not dissecting in the area of the RLN. How do you remove the gland without dissecting it?
You don't peel the capsule off the back wall. Instead of risking the danger zone, the surgeon takes a scalpel and slices directly through the meaty tissue of the thyroid itself.
Leaving a physical shell of thyroid tissue permanently attached to the back of the trachea.
Exactly, an almond-sized remnant. And because that posterior shell is left entirely undisturbed, the parathyroid sitting on it and the RLN running behind it are never even seen or touched.
The risk of nerve or calcium complications drops to basically zero.
But the trade-off is that you're leaving diseased tissue behind.
Right, that multinodular goiter could eventually regrow from that little almond 10 years later.
Or the Graves' disease might still act up. It's an exchange. You dramatically reduce immediate surgical risks, but accept a slight risk of long-term recurrence.
Okay, so the resection is done. Moving to slide 18, closure. The slide says, once resection is completed and hemostasis is ensured.
Ensured is the key word. You don't just look at it, see it's dry, and start sewing. You test it violently.
By asking the anesthesiologist to do a Valsalva maneuver.
Right. While the patient is paralyzed, the anesthesiologist squeezes the bag, forcing a sustained, high-pressure breath into the lungs.
Mimicking a massive cough.
Venous pressure in the neck skyrockets, and you watch the empty thyroid bed. If there's a microscopic vein you missed or a weak clot,
The pressure spike blows it right open.
it starts hemorrhaging instantly in front of your eyes, which is exactly what you want. You find it, fix it, and test again. You only close when a massive Valsalva remains perfectly dry.
And the closure is layer by layer. Strap muscles reapproximated with 3-0 Vicryl. Then the platysma with 3-0 Vicryl. Why is sewing that paper-thin platysma so critical?
Physics. When the patient wakes up and turns their head, the neck skin stretches. If you only sew the skin, all that mechanical tension pulls directly on your delicate skin stitches.
Stretching the scar wide open.
It'll turn into a thick, ugly scar. But if you sew the fibrous platysma together, it acts as an internal corset. It absorbs all the tension.
Leaving the skin completely tension-free.
Right. And then you close the skin with a subcuticular stitch using 4-0 monocryl.
Hidden completely inside the dermis. No staple marks.
And monocryl is a monofilament, a smooth, single strand. Unlike a braided suture, it won't wick bacteria into the wound. It dissolves, leaving a perfectly healed, nearly invisible line.
Slide 18 also mentions an option for a section drain.
Yeah, if you removed a massive goiter, you leave a giant dead space. Fluid wants to fill that space, creating a seroma.
A pool of fluid that bacteria would just love to infect.
So you slide a perforated silicone tube in, hook it to a vacuum bulb, and suck that fluid out continuously so the tissues can heal together. But if hemostasis is perfect and the dead space is small, many surgeons just skip the drain entirely.
Makes sense. Okay, heading into the final stretch. Slide 19. Complications.
The grim realities.
Tension hematoma is first. And you called this an absolute bedside emergency. If I get a hematoma in my leg just bruises. Why is the neck so lethal?
Because the anterior neck is a sealed box, bound by tough fascia in the back, and the heavy strap muscles we literally just sutured shut in the front.
That's locked.
Right. So if an arterial knot slips in the recovery room, high-pressure blood floods the box. It can't expand outward.
So it pushes inward, directly into the trachea.
The back wall of the trachea is soft and membranous. The expanding blood clot literally crushes the windpipe closed. The patient will start making a horrible, high-pitched crowing sound stridor.
And if you don't act,
They asphyxiate in minutes. You do not have time to go to the OR. You run to the bedside, grab scissors or just your gloved fingers, and forcefully rip the incision open.
You just tear the stitches out.
You rip through the platysma and strap muscles, plunge your fingers in, and physically evacuate the clot.
Relieving the pressure.
The second you open the box, the trachea springs open, they take a breath, and their life is saved. Then you take them to the OR to fix the bleeder.
Unbelievable. The other complications listed are the nerve injuries we discussed and the metabolic ones. Hypoparathyroidism. How does low calcium present at the bedside?
The nerves get hypersensitive. First, they feel tingling around their lips and fingers, paraspesias.
In Schwastek's sign.
Yeah, if you tap on their cheek over the facial nerve, their face involuntarily twitches. If calcium drops further, you get Trousseau's sign. Putting a blood pressure cuff on makes their hand cramp into a painful claw. Tetany.
Treated aggressively with IV calcium. And then there's hypothyroidism, which is really just an expected outcome of a total removal.
Right, they just take a daily levothyroxine pill for the rest of their life.
The final complications are cosmetic. Wound infection, or a hypertrophied scar, or a keloid.
And a keloid on the front of the neck is devastating. Fibroblasts just don't stop making collagen, resulting in a thick, raised, itchy, highly visible rope of a scar.
Which transitions us perfectly to the final slide, slide 20. Recent advances, driven almost entirely by the desire to avoid that neck scar.
Right. Endoscopic thyroidectomy via the bilateral axillobreast approach, BEBA.
This is wild. You insert a 12-millimeter camera port into the right armpit and working ports into the left armpit and around the nipples on the breast.
You don't even touch the neck with a scalpel.
You use long, rigid instruments to tunnel forcefully under the skin of the chest all the way up past the collarbones to reach the thyroid from below.
Like building a ship in a bottle, but working through a long tunnel.
And the slide notes you heavily rely on the harmonic scalpel here.
Because trying to tie a tiny silk knot around a fragile vein using foot-long sticks through an armpit is nearly impossible. The ultrasonic sealing of the harmonic makes this remote surgery viable.
But doing this,
yeah,
you completely lose tactile feedback.
Completely. In an open surgery, your fingers feel the tough fibers of Barry's ligament, or the soft, pearl-like feel of a parathyroid gland.
You feel the tension on the vein before it rips.
With BABA, that physical connection is gone. You have to learn to feel with your eyes. Judging tension and tissue density purely from a high-def 2D screen across the room, it requires immense, rigorous training.
It's just a total paradigm shift. All right, let us pull back from the operative field. It is time for you to pull yourselves out of the mental movie. Congratulations on completing this exhaustive, layer-by-layer mental rehearsal.
By visualizing these exact steps, from the avascular platysma plane down to the lethal traps around Barry's ligament, you're laying down the critical neurological pathway.
Building that deep autonomic confidence.
Exactly. When you implicitly understand the physiological why behind every single maneuver, the physical technique follows naturally and safely.
Well said. As we wrap up this deep dive, I want to leave you with a final thought to ponder. We've traced this incredible evolution from Kocher's classic hands-on, wide-open neck incision.
A profoundly physical operation.
Right, to these highly remote, complex endoscopic approaches like BABA. So, as we move inevitably toward purely robotic, remote-controlled surgery, how will the fundamental requirement of tactile feedback, the ability to physically feel the density of a parathyroid gland, evolve when our hands are completely removed from the patient and replaced entirely by mechanical arms and digital screens?
It's the challenge that will define the next generation of surgery.
It really is. Thank you for joining us in the masterclass. We'll see you in the next session.